Can you guys see my screen?
It's grayed out, but I see that there are pages.
Hold on. Can you guys see again? No?
It's still grayed out, but I can see that there are pages at the bottom. It says 1 of 4. You may have to...
I practiced in my Teams and it was successful. Hold on.
Okay, go ahead and maybe try again. It may just be the view that you picked wasn't quite the right one. And if you're not able to share it, then maybe somebody else in your group can. Yeah, I still see a grayed out screen, unfortunately. Oh, wait. Nope.
Did you guys see it?
No, I didn't. I just saw your Zoom screen.
Hold on. Again, can I from my team share the Google Doc? No, this is not the right thing.
That's okay. So who else in Pinkel's group can help?
I really want to discuss because I have your question.
Yeah. So who else is in your team? You should have, what, 5 other people?
Nabil, Brian, Patrick.
Great.
Mitchell texted me in the group that his internet now supporting him today. So
okay. So anyone else in the group, please help your team members out.
It was working perfectly fine.
So the other thing you could do is you can always send me the document and I can pull it up and share my screen and scroll down for you. So.
Oh yeah, that's the great idea. Hold on.
Okay. But I'm not thrilled that your teammates are not stepping in. It's sort of supposed to be the benefit of having a team, right?
Yeah.
Okay. All right. So go ahead and, Pinko, go ahead and send that to me and I will pull it up.
Okay, I just did.
Okay. And then you can go ahead and stop sharing and then I will share.
Okay. I'm not sharing at this moment.
Oh, you're not? Okay. Looks like you are. It says you're.
Right.
Yep, there we go. All right, we're out. Okay, thank you guys for being patient. As you know, sometimes hijinks happen with computers. I will pull this up very fast, and then I'm gonna let you drive. Let's see if I haven't gotten the email yet, and
you just did.
I did not. Okay, I haven't gotten it yet. It'll probably come through in a moment.
I'm sorry, guys. I'm just taking up everyone.
It's okay. You know what? It's all good. It's all good. If we need to extend this activity into other parts of the week, like, it's not the end of the world. So learning takes time. And I really appreciate you volunteering. All right, so let's see. I'm going to give this one more try, and if not, then unfortunately I'm going to have to probably have another group start off. Yeah, I still haven't gotten your email, which is bizarre. Yep. Okay, darn it. That's all right. Maybe for the next question, maybe your teammates can kind of get their stuff together so they can help. So team 1, thank you, Pinkle. You apparently.
I am so.
No, you're okay. Oh, wait, I got it.
Yes.
All right, this is exciting. Okay, sorry about this. Here we go. All right. You can see my screen?
Yes. Thank you.
Wonderful. Of course. And if you guys need me to zoom in, I can do that as well.
Can you please zoom in the picture that I like circled and stuff?
Absolutely. Okay. Oops.
It's more.
There we go. Let me see if I can.
It's okay. This is
okay. How about that?
No, I need to know the numbers for the panitumab table. And
okay.
Okay, perfect.
Okay.
So the first circle that so this is from the review article.
Mm-hmm.
That's where to summarize all this study. That's where I started.
Yep.
And I found out that they compared cetuximab in the patient population is refractory to irinotecan, oxaliplatin, and fluoropyrimidine. Mm-hmm. And their overall survival is 6.6 months. Mm-hmm. Versus for the same patient population, they use panitumab, and their overall survival is 8.6 months. So they're like, so looking at this table, what I felt is panitumab is giving 2 extra months to patient. And then I was curious that 2 months is statistical significant or not, and there is no study out there comparing these two drugs. Mm-hmm. And so I don't know 2 months is statistical significant or not. So then I was also comparing the other study where they had the same patient population, mutation for KRAS and wild type, and they're comparing drug with BSC is basic supportive care. Mm-hmm. And I found there is not huge difference in overall survival for the mutated population, right. But there is a benefit of using panitumumab instead of cetuximab in wild-type KRAS patient, which is 4.5 versus 8.1. Again, I don't know. The difference in this number is statistical significant or clinical significant or not. So then I went ahead and started digging into each studies, and what I found, can you please scroll down now?
Sure. Sorry. No.
Then I looked for the dosing, and then I was wondering how often patient will have to go to a clinic to get the chemo and how it work. And then it's pretty much weekly dose. So I think I figure out that's not a big issue. If they want to get better, they will have to come to hospital. I mean, mm-hmm. We will make them come. Then I was digging into another criteria that I was looking for is a price, and I found out that panitumumab is super, super expensive, and I wrote that underneath it. If you scroll down a little bit more. Yes, so panitumumab is $307 per ml versus $15 per ml for cetuximab. Is like a huge difference in price. This is what I got from Lexicon.
Okay.
So there will be a difference, like 2-digit versus 3-digit.
Yeah.
And also, and then when I was looking, so since I found out from that summary that panitumumab is like showing a better, like giving extra month to patient, I started digging more into the clinical trials for panitumumab. Mm-hmm. And this is when Custom et al. Study, they found out that 90% of the patient got skin toxicity. Yep. With this panitumumab compared to the supportive care, because that's what they were comparing. Right. And diarrhea was 21% and hypomagnesemia is 36%. So what I think, so there's no head-on-head comparison for cetuximab and panitumumab, is giving patient panitumumab, we're buying 2 extra months, but if they're going to leave, this is my opinion, okay? This is not from...
Yeah.
So
Please.
if they're going to leave 2 extra months suffering from this toxicity, skin toxicity, probably patient would not like living with the skin toxicity like acne. We don't know how bad it's going to be in the patient and how they're going to like it. Then diarrhea, 21% is also like scaring to me, because when patient have severe diarrhea, they will have electrolyte imbalance, and then subsequently say hypomagnesemia. So it's gonna also be a complication of QT prolongation, or like hypomagnesemia go along with hypokalemia. And then they might go into emergency situation where we have to like supplement electrolyte and all that. And then cost of care will also be increased. The quality of life is not promising to me in those 2 extra months where they're gonna live. That's given by panitumumab. So considering all these factors, the side effect for 2 extra months, and a cost, and then cost of supportive care, where they're going to go on hypomagnesemia and what emergency care we have to give it to patient. And from that consideration, I think I should not have panitumumab in my formulary where cetuximab is serving the purpose.
Awesome. Okay, so a couple questions for you. So for the cetuximab, when you looked at the cetuximab specific studies, were the toxicities pretty much equivalent between cetuximab and panitumumab?
You know what? I did not pay close attention, or I may need more time to read those studies.
Okay.
But I was just, so my first question is, this 2 months is statistical significant or clinical significant or not? And then I only read panitumumab study for the time frame I had available.
Sure.
I should have more time spent to cetuximab study as well, but
no, that's okay. That's perfect. No, and actually that's the good thing about this is, in general, you're going to have like just one drug. I mean, it depends on kind of what the situation is. Often we'll be given 2 drugs that we have to compare to. Sometimes it's just, you're given one drug to kind of review and see if, especially if it's a new drug, if it should be added or not. So this is an awesome start to this. And thank you. So your question about statistical versus clinical significance is a really important one.
Yes.
And it's actually one that I wanted us to talk more about when we talk about ethics next week, because this is something that really is very powerful, because what is clinically significant to a patient, like from a patient's perspective, may be very different from a clinician's perspective, because a patient is thinking to themselves, I could get 2 extra months. In that 2 extra months, I could do X, Y, and Z. So it's hard, because as a provider, I'm thinking, okay, yes, it could potentially give you 2 extra months, but it might not, right? Because that's an average. That's not necessarily what happens for every patient. Some patients live longer than that. Some patients live a lot less time than that, right? That's where we come up with that 2 point whatever number. So, then patients think, well, maybe I'm going to be the person who got an extra 6 months. So that's kind of where this is really tough, because we really don't know. So I would say that for diabetes, for like heart failure, for a lot of asthma, if you're looking at overall survival for an intervention, any other clinician would see 2 months and probably say, that's not significant. Like, we're not going to change our practice because somebody is maybe going to live 2 extra months with something like heart failure or whatever. When it comes to cancer, it's a little bit of a stickier situation for that conversation, because there's this predominant driving force in oncology care that's, well, we have to do everything we can for someone until we give up. So we have a very different kind of ethos about how we treat patients versus other kinds of chronic conditions. And I'm not saying it's good. It's simply just what the standard of care has been for a long time. We keep going until a patient says no more, or until a clinician literally says, I'm so sorry, you have 2 weeks left to live. You need to go on hospice. So one of the other things that I think about too is when I look at those numbers, about 2 extra months, I also often will try and compare to quality of life studies to see if any quality of life studies were done on that same drug specifically. Because if the quality of life scores are really bad for that particular drug, then an additional 2.5 months or 3 months may not be statistically, well, it may not be clinically significant. For panitumumab, so one of the things that helps me is that personally, I've had tons of patients over the last 10 years on all of these drugs, and many of them on them for years. So what I can tell you about cetuximab and panitumumab is that they're fairly well tolerated. We do have to give medications for the acneiform rash. Those can be severe, and in patients who have grade 3, we stop and we don't start again. But for the most part, if we do what we're supposed to do, we can stop the rashes at about grade 1 or grade 2. And the diarrhea, kind of generally will get a little bit better over time when a patient's been on the medication for a long time. But hypomagnesemia is a big issue, and we often will treat it by giving them a gram or 2 of mag before we give them every dose of cetuximab or panitumumab. And that usually kind of staves off that. But that's an additional cost, right?
Yes.
You're having to infuse, that's more chair time. So we can give 2 grams of mag in 1 hour, not usually faster than that, unless someone is severely hypomagnesemic, and then they're going to be in the hospital. So you're absolutely right that you brought up all the important questions. Cost-wise, I don't think Lexicomp gave you guys the accurate cost, only because from personal experience, the cost of acquisition of cetuximab and panitumumab have been about the same. Although I think it makes sense that panitumumab is a little bit more expensive because it's not used as much. Okay, so that was really good. Can anyone, so for those of you who chose, another team who did choose cetuximab, can you tell us sort of what some of the toxicities that you found, and kind of compare it to the data that she provided about the tolerability of panitumumab? So if someone could maybe show us that data, and I'm going to stop sharing. And
thank you for sharing this for me.
Yeah, and for any of you, if you're having problems with that, just send me the document and I'll share it for you, okay? So don't have any anxiety about that. And thank you so much, Pinko. That was really helpful. That was a great place to start too. Okay, so other team, please participate. So who has data about cetuximab and wants to compare it to the panitumumab data that she's got here for toxicities and for overall survival? Anybody before I have the P4s take over? I'm going to start picking people. I hate doing that.
I have a question.
Yeah.
Actually.
Sure. What's up?
So she mentioned that they were both dosed weekly, but when I looked them up, I saw that panitumumab was every 14 days.
Mm-hmm. Yep. So there are actually different schedules for cetuximab and panitumumab. What I can tell you is that also in some clinical settings, cetuximab will be given every 2 weeks as well, instead of weekly. I
have a clarification on that, because the Lexicom information there every 14 days, but then the study, what they schedule those is what not that much a difference between those. So I keep thinking about that.
Yeah, no, that's totally okay. And so one of the problems with cetuximab